It is 8 o'clock, so we are going to go ahead and get started. We'd like to welcome you to the ABIN monthly webinar. Thank you for being here this morning and spending this time with us. We do want to remind you that this webinar is being recorded, and by staying on today's webinar with us, you're giving us permission to record you, and this recording will be posted to the ABIN website. So if you know of anyone that's interested in this topic that couldn't participate today, please direct them to www.abinnetwork.org, and we will house this there. And with that, I'm going to turn it over to Dr. Gibson, who will introduce Dr. Novack.
Yeah, good morning, everybody. I'm excited to be here and have Dr. Amanda Novack talk to us. I met Mandy as a female physician colleague in our Baptist system, and have just gotten to know her more as a person before knowing just her expertise as a physician. I had been hearing at Baptist about, well, this great physician who is leading the pandemic effort at Baptist. And it took me a minute to go, oh, that's Amanda Novack. So she's somebody that is a people person and who is real and authentic and who has a passion for wellness. And also has fantastic credentials. She is from Arkansas, graduated from Hendrix, med school at UAMS, residency at UAMS in internal medicine, and in a fellowship in infectious disease, been on faculty at UAMS, and worked with Arkansas Department of Health, very much about antimicrobial stewardship and infection prevention, working around the state. And since November 2019, she's been medical director of infection prevention for Baptist Health System, and that put her in the spotlight leading the response to the pandemic. And now she's recently been named the medical vice president of quality and safety at Baptist. So she does live in Little Rock, and we were just talking about how she says she has too many dogs. So that really speaks to that. We often have our dogs in our laps for a lot of our meetings. So when we were looking as a part of our OUD grant, we know that it's really important to assess and treat patients who have substance use disorders for infectious disease. And so when we were trying to think of how could we best bring this information to our audience and to the state, Dr. Novack really came to our mind, and she was excited to speak with us. So so glad that you're here, Mandy, and happy for our audience to get to hear you.
Well, thank you so much. I'm going to have you do all my introductions from now on. That was very flattering. I realize I don't have it in the slide, so I'm putting the phone number of our viral clinic as a resource. We do HIV and Hep C care along with pre-exposure prophylaxis. So that's the one thing I forgot to put in my slides. So I wanted to make that available to y'all. So yes, there is a lot here, and a lot of it I'm going to end up sort of skimming the surface because there's just so much to cover. But there's a lot of overlap between infectious diseases and substance use disorder and opiate use disorder specifically. So we're going to just talk about some of those common manifestations and talk about risk mitigation strategies and some ways that I found for modifying the treatment plan. You know, sometimes because of various psychosocial factors, we can't always do what the textbook tells us to do to treat these patients. And so I'll go through a few of those. I think most of you are probably familiar with these terms, but I use them in the presentation. So persons who inject drugs, IDU, IE is injection drug use related infectious endocarditis. And I talk about ART and DAA, which antiretroviral treatment for HIV and direct acting antivirals for Hep C. So I have a couple of cases to talk about, and I specifically chose both of these cases because because these are people that have actually since recovered or in long-term recovery from their opiate use disorders. And I don't know, I think it's valuable to talk about why we risk mitigate and why we try to reduce risk while someone's battling their substance use disorder. And, because there is hope for long-term recovery at some point, and we just have to bridge that. So this was a 43-year-old man presented to the ER, heard a crack when he punched someone in the head. So he presented for this right hand pain, and he had this very typical boxer's fracture, and they splinted that. But the ER physician looks over and says, "What's going on with your left arm?" And guy says, "Oh yeah, that I missed a vein." So the ER doctor was, much more concerned about this than the boxer's fracture, and ended up getting a CT scan. He had diffuse abscesses and myositis, and ended up going to the ICU. Became floridly septic within a few hours after his presentation, and required multiple debridements to get that under control. So skin and soft tissue infections, this is the most common cause for hospital admission in persons with who inject drugs. So his actually looked like cellulitis and turned out to be lots of purulence underneath that. Sometimes it's obvious where the injection site was, and but sometimes you can't actually see the injection site. There's just fulminant cellulitis. Probably more than half of these are going to be staph aureus, so MRSA or MSSA, and an empiric treatment should always include coverage for MRSA. Also, pretty frequently we'll have strep infections, and then skin and soft tissue infections in people who don't use injection drugs tend to be fairly simple. It's either strep or staph. In people who inject drugs, they can take on much more rare organisms. They're often polymicrobial. Oftentimes we'll have anaerobes. Clostridium infections are much more common in this population. And so the treatment, and this is crude, but I learned this in residency from Dr. Dick Jacobs at Children's. Piss and pus must pass. If someone has an abscess, it has to be drained. You can give them every antibiotic in the world, and if you don't actually let the pus drain out, then you're not going to cure it with antibiotics. When you see these people in the clinic, it's not always necessary to get imaging, but when they present to the ER, we tend to get either an ultrasound looking for fluid collections, or CT scan, sometimes MRI if you're concerned about joint involvement or bony involvement. Usually, if it's just simple cellulitis, in most patients, simple cellulitis without an abscess, you can just treat for strep. So penicillins and cephalosporins are actually great for that. In these patients, you generally want to cover for MRSA, even if you don't see a fluid collection, just because it's so common among these patients. And sometimes, like in the case here, these infections can get very complicated. This is a very abnormal way for bacteria to get into the skin and soft tissue. And so it can go places that usually bacteria don't go. And it can sometimes take very aggressive multiple debridements. Sometimes can involve neck fascia that usually becomes pretty obvious. These patients are very, very ill, and it's a very rapidly spreading infection. They can also pretty commonly become bacteremic or septic. This particular patient had to be treated along with debridements. They specifically did a fasciotomy for compartment syndrome, and sometimes the scarring can be really extensive. So this is his scar from the fasciotomy. It doesn't show, it's really impressive in real life. It's nearly an inch wide. So these are, crack marks can come in a lot of different variations. They don't all need antibiotics. They're prone to infection, but but sometimes exposing people to antibiotics where there's not truly a cellulitis just, increases the risk of other complications from the antibiotics. And so I really am looking for a pretty hot, swollen, red, streaking sort of picture before I would do antibiotics. I probably would treat all of these topically, maybe some topical mupirocin, but just good CHG cleansing is also good. I also, the most common place to inject is going to be the arms, and that's probably where we see the most abscesses and skin infections, but have to look these other places. People get very crafty. In between the toes is actually a pretty common place to inject. For one, if you've run out of other veins, but also, sometimes people want to be discreet, and it's a good place to hide your injection sites. There's also the groin is fairly accessible. The veins there are pretty easy to get to, but that's also, not a super clean area and tends to be really prone to infection too. So moving on to my next case, this was a 33-year-old woman who presented with fever and shortness of breath for a while. Couldn't really tell us how long, been feeling bad. She was somnolent. It was hard to tell if this was, true encephalopathy or just intoxication. Her urine drug screen lit up like a Christmas tree is what the ER doctor said. So positive for multiple different drugs, including methamphetamines and opiates and benzos. So in the ER, she's febrile, she's tachycardic, she's getting hypotensive with a pretty wide pulse pressure there, a little bit on the low oxygen side. She just looked a mess. She had sores all over her body, all over her face. She was pale. She had like a med student sort of murmur, where, you can bring the first year med students in and they can hear that. She had splinter hemorrhages in her fingernail beds. CT chest showed she just has emboli all throughout her lungs. And then echo showed a large aortic vegetation and then severe tricuspid regurg. So she practically didn't have a tricuspid valve. There wasn't a vegetation there at that point, but it had just been eaten away. So the textbooks will tell you that the most common site is tricuspid valve. And certainly if you see a tricuspid valve endocarditis, you should be concerned about injections. We see that in hospitalized patients that have IVs. It's not always illicit drug use, but really, oftentimes these patients will have other valves involved. And in this one, her aortic valve was involved. The demographics for endocarditis are different in patients who inject drugs. So mean age is 38. I've seen them as young as 18, and that's only because I don't work at Children's. I imagine they come younger than that, as opposed to sort of traditional endocarditis, which is an older population. So I have found sometimes it is hard to get appropriate treatment for these patients. I have had times where it was hard to get them a clearly indicated surgery because there's sort of this idea that they're hopeless and they did this to themselves, and so why even bother? And so the indications for surgery are typically just what they would be if you didn't have a history of IV drug use. So if the valvular disease is so bad that you're in heart failure, if they continue to be bacteremic despite antibiotics for 5 or 6 or 7 days in a row, if they've got emboli, the fear is that if they're shedding emboli to the rest of their body, they can easily shed them to the brain or infarct their spleen or their kidneys. Certainly, if they've had a valve replacement in the past and now that is infected, that's an indication for surgery. Paravalvular abscess, conduction abnormalities whenever the infection involves the electrical system of the heart. And then I said abscesses, I meant large mobile vegetation. So if you've got a big floppy vegetation, the odds that that flex off and goes somewhere is a lot higher. And so that can be kind of a soft indication. And then these patients are much more likely to have a fungal infection. Candida endocarditis is basically unheard of in any other population except people that inject drugs. So, but having a fungal infection, a Candida infection, or a very resistant Pseudomonas or other organism would be indications for surgery. And the treatment for endocarditis is 4 to 6 weeks of IV antibiotics. And so now you have someone who's just proven that they have an issue with injecting drugs, and now you need to inject drugs for 4 to 6 weeks. There's conflicting studies out there on how safe it is to do this. I think the general consensus is that there are ways to send someone home with a PICC line and with IV antibiotics. I tend to really emphasize to people that this line goes straight to your heart. And obviously we talk about the importance of not using that for anything else. The truth is, I mean, my personal take on it is, obviously these people were using IV drugs without a PICC line. I don't think that not having a PICC line is going to keep them from using injection drugs, but my real preference is to get them on medication-assisted treatment, especially if they have opiate use disorder. Suboxone can be very effective at preventing relapse while they're on antibiotics. These patients have a tendency to leave AMA. They, have high tolerance for opiates most of the time, and their pain is very difficult to control. And they're often, disenfranchised or not treated. It's a mixed bag. They are difficult patients to treat, but they also they have their concerns sometimes ignored too. So they're much more likely to leave against medical advice. Up to 25% of these patients will have a recurrence of endocarditis, and if that happens, the mortality is really high. Is a really, really bad prognosis to get endocarditis a second time in the year. These patients often have other infections as part of the endocarditis. They have embolized to their spine or to their joints, and so they can have very painful infections in other places, even if you address the heart valves. And piss and pus must pass. If they have a septic joint or large abscesses, those typically have to be drained or debrided as well to really get the infection under control. And like I said, the substance use disorder should absolutely be treated. The reality is, in our hospitals, we have a paucity of addiction specialists. It is sometimes very difficult to treat someone's infection and their substance use disorder at the same time. I actually got my Suboxone waiver in 2018 at the Infectious Disease Society of America annual conference, that there was such a need identified among infectious disease doctors that these patients, I can treat the infection, but if no one's treating the opiate use disorder, then they're going to inject again and they're going to get infected again, and that we're just sort of spinning our wheels, that I can't really treat the infection without treating the substance use disorder. So I think we are making progress in that direction. I think people are recognizing that we really have to do both, that we can't just send someone on IV antibiotics with a list of phone numbers for potential help. But I still think we have a long way to go to really getting people the care that they need. The other thing is it's hard in Arkansas to find an acute rehab that will take someone with a PICC line. So I think that's another area that I think we're making progress in that area too, but a lot of times these people, they need intense substance use disorder treatment. They need inpatient rehab. We can often detox them over the course of the hospitalization for the acute infection, but then they still need really intense treatment. And if you've got another 6 weeks of IV antibiotics, a lot of acute rehabs are uncomfortable with that part. And so finding that medical treatment and the mental health treatment that they need So how are we on time? Okay, I'm going to move on to HIV. So about 30% of global HIV infections are transmitted by injection drug use. It's probably not quite that high in the US, but is percentage wise. Persons who inject drugs should be tested for HIV at least once a year. There's also, even those that don't inject drugs, but have other substance use issues, whether they smoke or snort or ingest in other ways, or sometimes those behaviors are associated with other higher risk sexual behaviors and often would benefit from more frequent screening as well. And then there's the data is a little bit mixed, but sometimes patients that have acquired HIV through injection drug use are less likely to get into care and less likely to be virologically suppressed. And so HIV pre-exposure prophylaxis reduces the risk of getting HIV from sex by about 99%. I mean, it's incredibly effective at preventing sex between, or it doesn't prevent sex, it prevents transmission of HIV between discordant couples. So where one has HIV and the other doesn't. It's not quite as effective at preventing HIV from injection drug use, but still certainly more effective than nothing, and can prevent quite a bit of the transmission. Most of this comes from this big Bangkok trial from several years ago, where they used prophylaxis, and that's where they got these numbers from. So I am a huge fan of pre-exposure prophylaxis. I think that, and perhaps it's just Gilead and the drug companies that have done such a good job of getting the word out, but oftentimes in communities of men who have sex with men, they're very knowledgeable about pre-exposure prophylaxis. They will often come into care saying, I want to get on PrEP. They can tell me which dose they want to be on. They're very proactive, but not as much in the injection drug use population. And so I just grabbed these off the internet, but when this first became a thing, we really thought, you need to be ID trained to be doing this. And, to treat certainly complicated HIV, I recommend, a specialist, but for pre-exposure prophylaxis, it really is pretty safe and pretty easy. And so we even now, as of last year, we have cabotegravir, which is an injectable that can be given on a monthly basis, it's every other month after you've given 2 months in a row. And, that I have several patients on that for prophylaxis, and it, you just have to think about it 6 times a year, and is protecting them all the time. So I feel free to reach out. We're happy to do PrEP in our clinic, but I also, I think, certainly most primary care providers are competent to do that. So good question about insurance paying for PrEP. I don't know about 100%. I will say most of my insured patients have no trouble getting it paid for. I say no trouble. It's a little bit of a headache paperwork wise. Many of them require a prior authorization. But I don't know of any big major payers that are not covering pre-exposure prophylaxis. It is certainly an advantage cost-wise for them to prevent HIV rather than treating HIV. I will say the Ryan White program in Arkansas, which is the federal funding for HIV care, I really, for all the places we're behind in healthcare in Arkansas, I think we really do a great job with our federal funding for HIV care. And there is not an HIV patient that cannot afford care in Arkansas. We will get them covered one way or another. We have a great safety net for HIV treatment. The place that their hands are tied is with pre-exposure prophylaxis or even post-exposure prophylaxis. It's very hard to get Ryan White money to pay for someone who doesn't have HIV. That funding is intended for people who have HIV. And while, the powers that be recognize that preventing HIV would also be good use of those funds, currently, that's not a source of funding for pre-exposure or post-exposure prophylaxis, only for treatment. And then here's those numbers showing that, for gay and bisexual men with HIV, they tend to get better care. I think it's part of that population. The community is very, empowering and self-advocating, and they've done a great job of helping get each other plugged into care. Whereas others with who use injection drugs are less likely. And then here's some other social and economic factors that limit the access for HIV treatment with among persons who inject drugs with HIV. So a lot of them are homeless. People that are incarcerated in the prison system can have access to treatment. And in fact, sometimes I've had patients who had better care while in prison for their HIV than I was able to get them outside there. But like I said, in Arkansas, these shouldn't be barriers that we really do. Our care is the contracted entity that provides a lot of the Ryan White support in Arkansas, and we have a really we can just always get an HIV patient in Arkansas into treatment. I'm going to move on to Hep B. I don't have that much to say about Hep B because there's an excellent vaccine against it. Most cases of acute Hep B in the US are related to IV drug use. It is extremely contagious. That's why healthcare workers all have to be vaccinated, because a needle stick, if you get a needle stick from a patient, your odds of getting HIV are actually really low, and Hep C is not that great either. It's there and we do prophylaxis, but the truth is those are not such a big deal. Hep B is remarkably contagious through blood contact. And so if you are sharing needles with someone who has Hep B, the risk of transmission is extremely high. So, for HIV and for Hep C, I say test annually for persons who inject drugs. For Hep B, I say test them once and then vaccinate them. And then you actually, we often will get a hepatitis panel on these people that continues to test for Hep B, but it's a very effective vaccine, and there's really no reason for anyone to get Hep B in the US anymore. And so this is an updated MMWR from last year where CDC came out and said, let's just go ahead and vaccinate everybody for Hep B. Certainly this population, and I would even say anytime they present or interface with care would be a good time to vaccinate them. Hep C. So Hep C is a problem because more than half of the people that get infected with acute Hep C will develop chronic infection. And so from this research we have, 66% of new cases report a history of injection drug use. It's actually probably higher than that. It's hard to get Hep C any other way at this point. We have discordant couples who have sex for years without ever passing Hep C. It is, largely from injection drug use at this point. All adults should be tested at least once in their lives. Women are supposed to be tested every pregnancy. And then again, sometimes persons who inject drugs are not necessarily attending clinic on a very regular annual schedule for their health screening, but kind of when they interface with care is a good time to get them tested. And the reason, well, let me go into testing a little bit. So if usually you'll start with a hepatitis C screen, which is just a Hep B antibody. If that's non-reactive, pretty good chance they don't have Hep C and they've never had Hep C. If that's reactive, it's probably because they have been exposed to Hep C at some point. Most, but not all, hepatitis C antibody tests will reflex to a viral RNA, a PCR test that actually tests for the virus. So if you get a positive hepatitis screen, the next step is typically to test for the HCV RNA. So if that doesn't reflex at the lab that you're using, Before I'm going to do anything else in their care, I'm going to get that PCR to see if there's active virus in their blood. If their antibody is reactive and their Hep C RNA is undetectable, then typically that means that they had Hep C and their body cleared it on their own, or that perhaps they've already received treatment that was effective. Occasionally you'll have someone that's hovering around the threshold where their RNA is negative and then it's a little bit positive again. But most of the time, if you get a positive antibody, but the RNA is undetectable or not detected, then that person does not have active Hep C anymore and they don't need treatment for it. And usually, it depends on the patient. Sometimes I'll test them a second time for the RNA just to be sure. And if that's negative as well, then I feel comfortable saying, like, you had Hep C, it's gone. You're still at risk of getting it again. These antibodies are not particularly protective. People can be infected over and over. You still need to be careful, but you don't need treatment. If the RNA is detected, then they have a current Hep C infection. Most of the time, practically speaking, that's going to be a chronic infection. It's very unusual to capture somebody in that acute phase. They just don't tend to be that sick during acute Hep C. And in that case, we want them to get treated. Here's just some statistics about Hep C. Like I said, to capture acute Hep C is pretty rare. It's, usually it's kind of a subclinical presentation, but 100,000 newly reported chronic Hep Cs during 2020. So lots and lots of Hep C going around and plenty to be had here in Arkansas. So treatment, I love treating Hep C. It is one of the few things we can cure. It's a chronic infection that used to kill people of cirrhosis, and now we can cure it. That's just so rare that we get to do that. Usually in 8 to 12 weeks. I mean, the treatments are really easy, really generally very well tolerated. I mean, especially those that can remember the days of peg interferon. This is night and day. Ironically, and I would say stupidly, many payers are still requiring that someone be clean and sober for 6 to 12 months before they'll pay for direct acting antivirals. I say stupidly because these are the people that are sharing needles. So if you actually want to do something about preventing Hep C at the population level, these are exactly the sort of people that you want to cure. I do understand these are still rather expensive medications, and if someone continues to use them, there's certainly a chance that they will reinfect themselves. But if we treated everyone with Hep C at the same time, then there would be no one to reinfect with. So there's just a little bit of irony there. So in a lot of states, and I forgot to mention this with HIV, but it is a crime to knowingly transmit Hep C to another person. Again, ironically, 12 states don't allow needle exchange programs. And so it's illegal to give someone Hep C, but it is also illegal to use a clean needle. So sorry, some of my biases are coming out, I know. So there are studies showing that persons who inject drugs respond well to antiviral treatment, that you can cure their Hep C. There is no evidence to support restricting Hep C treatment. Some payers, I think the payers are figuring out that it's easier or cheaper to cure Hep C than to treat cirrhosis. And so the restrictions around how your fibrosis score or how sick you need to be before they'll treat it, those are getting sort of more and more open, where we are, a lot of payers will pay even before anyone has any evidence of liver disease. Just by having active Hep C, they'll pay for the treatment. So these are just general risk mitigation strategies. And like I mentioned, Hep B, that's an easy one. I think that pre-exposure prophylaxis, patients with substance use disorders should be counseled about prep about the pros and cons, and there's a lot of good stuff on the internet where they can read for themselves. But it's both, here I would say not just injection drug use, but anyone with a substance use disorder where they can't necessarily always have agency over their sexual choices. And then I will sometimes educate about post-exposure prophylaxis too, because sometimes, I mean, it's not uncommon for someone to have injected drugs with someone or had an encounter and then, quickly find out that that person was sick or that person, maybe had HIV. And so I talk about, if you think you've been in a situation where you were very likely exposed to HIV, past tense, then we can use a 3-drug regimen to help prevent treatment. We always test those people before we start that regimen. I know it doesn't have that much to do with infections, but I'm a big advocate for Narcan programs. I think that, again, if our goal is to keep these people as safe as possible until we can get to them to a place of better health, then Narcan's an important part of that, and then fentanyl test strips too. And then I'm going to talk a little bit about safe injection practices, which kind of at the national level, the Infectious Disease Society of America and the CDC are, advocates for risk reduction. And so I'm going to talk about how we do that. This is the naloxone program. I imagine many of you are familiar with this. We've over the last few months gone live with this. I think we're live with this in all of our ERs across Baptist, but where we can dispense free naloxone to patients or caregivers who are at risk of an overdose. And I think the more you work with this population, the broader your sense of who's at risk for an overdose becomes. But, the goal is really to have naloxone in the community. So when it's needed, it's there. To me, it should be like an AED or CPR certification that, we want it as available in the community as possible. So, when someone comes across their friend not breathing, that it's available to them. So here are some handy sites about safe injection practices. A lot of these are very consumer friendly. They're geared toward the general public about how they can reduce harm around injections. This is straight from the CDC. So SSPs, syringe services programs, are needle exchanges and syringe exchange programs, often linked with other substance use disorder treatment, sometimes paired with Suboxone clinics or methadone clinics. There's this education going out about how to decrease risk around injection drug use. This is North Carolina's site. I don't know, I put it on here because I just love the way they say it. Like, injecting drugs is risky. There's bad things that happen with that. We don't encourage drug use. And I think there's this fear that, like, if we do anything to risk mitigate, if we do anything to make this safer, then that will be a big shiny endorsement for drug use. Nobody here is encouraging the use of heroin or IV meth or, we don't have to encourage it. We're mitigating the risk. And so we encourage safer use for active injectors. Like, just because we don't endorse the drug use doesn't mean we can't be helpful in, preventing bad things from happening to these people. And then I also appreciate lowering disease transmission saves taxpayer money on treatment and decreases the number of syringes in the community. This is really, everyone wins. Nobody loses with safer injection practices. And yet, here we are. So this is a map of available syringe service programs in the US, and you can see Arkansas and much of the Southeast Conference is in that red category. And so, so this is kind of the way the law's written. is that syringes are considered drug paraphernalia, and they don't have any exemption for these sorts of syringe exchange programs. So you can't, so anyone setting up a syringe exchange or needle exchange program could be prosecuted for having drug paraphernalia. And yes, I believe it will take legislation to actually get this changed. And I think the general mood in the country has been toward, obviously the map is getting less restrictive. But yes, Arkansas legislature would have to change the laws, or they could either specifically put in language about protecting these SSPs, that they're not going to be prosecuted. Other states have kind of taken it a step further, where it really is very kind of patient-centered, where these are even, in some places these are government funded. Certainly we're a long way off from doing that in Arkansas, but we could at least decriminalize using that. So these are taking the controversy out of it. This is, the basics of what I would tell anyone who injects drugs. And some of it is really basic infection prevention. And some of it feels silly, even saying it, but the reality is, addiction is horrible and it ravages lives. But that doesn't mean these people are unteachable. And oftentimes, if you tell them ways that they can be safer about this, they will implement those. And so saying things like wash your hands before you do this, is a clean area, wipe down the area with bleach, clean the skin with alcohol, that these basics that we do in the hospital before we draw blood or start an IV are useful in other areas too. One's not so much infection related, but like not using alone. Don't lock yourself in an area that is difficult to get to, just in the sense of overdose prevention, and, teaching people the difference between a vein and an artery. And then this on the right is actually from the CDC. It teaches people how to clean your syringes. And so even in states where there's not a syringe exchange program, there are ways to make these things safer. The truth is, if someone cannot walk into Walgreens and buy a bunch of needles and syringes, they're gonna reuse their syringes and needles. And so just some basics about how you can do that safer, how you can prevent bacteria and viruses from being in those reused needles. And then this stuff gets a little bit more bold. I'm like super comfortable saying all of that. I'm pretty comfortable saying most of this, but I think any of us should be comfortable telling people to wash their hands, explaining how alcohol cleans the skin, so the bacteria that on the skin doesn't go into the vein. These are some other things that are out there on these websites about how to inject more safely. It's like, it kind of hurts to say it as healthcare providers, but it's still helpful. So if you're in a bathroom and all the water you have is from the toilet, use the tank, not the bowl. I know that's so silly, but it's just true. It's 1,000 times cleaner in the tank than it is in the bowl. Telling people how they can sterilize their water by boiling it in the same way that they do their cookers. Telling people, if you miss your shot, so if you didn't make it into the vein, like, stop injecting, get rid of that, clean all of your stuff, and then go up higher. Rotate your veins. That using the same vein over and over is sorry, I'm trying to read questions and talk at the same time, but that you can, those veins wear out. You're more likely to get an abscess or a skin and soft tissue infection if you keep going back to the same site. So moving around your sites. This part I don't get it as much into this, but the reality is the same issues that we have in the hospital trying to start an IV or trying to draw labs on somebody are an issue out there in the population too. And if you have rolling veins, if you miss a vein, you are much, much, much more likely to get a local infection there. Teaching people about bevel up and the angle of the injection, about using tourniquets. Again, these are things that we don't necessarily think of, but there's a reason we use tourniquets in the hospital. It's easier to hit the vein and to not miss. And then teaching people to not slam it, to go slowly. That reduces the risk of overdose. And also, there's injecting too quickly is more likely to blow a vein and cause some local irritation that can lead to infection. So I realized when I got done with all that I still had this whole section that I didn't have, and I was about right on my time. So so I wanted to talk for just a minute about what we do when these patients present with endocarditis, with osteomyelitis, with other infections, and it's hard to get them home with a PICC line, or it's hard to keep them in the hospital. And so the cabotegravir and rilpivirine, so I say plus or minus because the cabotegravir alone can be used as that pre-exposure prophylaxis. Adding rilpivirine makes it a full HIV treatment plan. And so if we have patients with HIV who cannot reliably take a pill or a group of pills every day, that using injectables, it's an IM shot, we give it in our clinic or in the pharmacy, can be a way to get them reliable HIV treatment without having to deal with the housing insecurities and so it's hard for a homeless person to keep up with their pills. And so that's a way that we've worked with this population to treat their HIV. Linezolid is an oral anti-MRSA drug. It's 100% bioavailable. It's a pill that's just as good as an IV. It's really useful in a lot of ways. A couple of things about linezolid. One is if you use it for more than a couple of weeks, it starts to cause bone marrow suppression and increased risk of neuritis. So we don't like to use it for very long. And it also has a serotonergic effect with, and so when mixed with methamphetamines, it can cause serotonin syndrome. So I'm a little bit more cautious with meth users. The concerns about serotonin syndrome and linezolid have probably been, now we've mostly dispelled those, that it's not a major concern, but something to be aware of. We also sometimes, we can bring someone into an infusion center if we're down to a once daily medicine. So daptomycin is a once daily MRSA treatment. Televancin's another one where, they still have to go in IV and they still have to go in daily, but they can come and get them done daily through a peripheral instead of through a PICC line that they go home with. Dalbavancin and oritavancin are both, I think of them as long-acting vancomycin. So they both have a half-life of somewhere between 1 and 2 weeks. And so one dose can last for, 10 days, which is not ideal. They've been studied in endocarditis and osteo, and it's not good enough for an FDA approval, but in a pinch, it is certainly better than just an oral antibiotic against MRSA or no treatment at all. Delafloxacin is an oral quinolone like levofloxacin, but it has MRSA activity, unlike the other quinolones. And so that's another oral option with good bioavailability. It also has some activity against other gram negatives that can be sort of resistant. So those are kind of my best bets. Occasionally, none of those are options either, and we just have to truly choose an inferior oral option. So, I would never want to treat endocarditis with an oral doxycycline or Bactrim, but I personally am a big believer in if these patients want to leave AMA, that doesn't mean that they're not entitled to the best care that we can provide outpatient. And so I will usually, try to give them, I'll give them suppressive therapy with antibiotics with 11 refills if that's what it takes. If they have MRSA endocarditis, I'm not going to cure that with pills. There's no way, but I can at least mitigate that and keep them from becoming fulminantly septic and sometimes keep them alive long enough for them to get into care. So this is Jason. He's my friend from the first case with the cellulitis and the broken hand. He has been in recovery. He works in recovery now. He's been clean and sober for over a year and a half and works at a treatment center. And I don't know, just a great example of why we treat these people humanely and with the best healthcare that we can provide them. So I think we have a little time for questions.
Dr. Novack, thank you for that amazing presentation. I wanted to ask, this isn't about medications, but it's about fentanyl strips. Would you talk a little bit about fentanyl strips, your thoughts on fentanyl strips? We hear that there's some controversy over that, and thoughts, ideas, and any hope that these will become accessible and usable?
Yeah, I think that's a good question. And they're certainly not the cure-all that we hope. And I think a lot of you probably know fentanyl is a little harder to detect. Our routine drug screens that we used up until a few months ago at Baptist didn't include fentanyl. So you could have a ton of fentanyl in your system and still show up opiate negative on a drug screen because it's requires specific testing. They are not perfect. I do think in the in the community of among people who inject drugs, there's this dichotomy where they're struggling with addiction. They'll go to any lengths to get the next high. They they don't have a lot of choice in what they're using, but many of them are also, many of them have had friends die of fentanyl overdoses, and many of them are very aware that fentanyl is dangerous, that it is lacing more and more drugs in the community, that it's not just it's not even just in other opiates. I mean, it's one thing to get a little fentanyl with your heroin, but now people are mixing it with their meth and other drugs. And so, many people are aware that fentanyl is dangerous. And this isn't necessarily about strips, but it is in, I just read yesterday in New York, they have taken to social media and other in Reddit and other networks when a bad batch shows up in the community. So if either through wastewater testing or just through narcotics arrest testing, they find that there's a particularly potent batch where there's a lot of fentanyl in a batch, that they'll actually get that out into the community. Hey, there's a bad batch going around, that what you're dealing with is more dangerous. I think that we're doing a better job in the community of educating that just touching fentanyl is not dangerous, nor fentanyl, which is a lot harder to come by. That's where most of those rumors got started, where it is actually is so incredibly potent that even very minor exposure can cause respiratory depression. But that if a police officer or a paramedic comes across someone with an opiate overdose, there for a bit we saw people that didn't want to touch them or resuscitate anyone because they were so scared of coming in contact with it. And I think we've gotten education out that it's not that dangerous. But the strips, I don't know how practical they are right now. I think for law enforcement, we're making some ground. I think in the community of people using IV drugs, I'm not sure how useful they are. I know that was a big hedge of an answer, but
I just want to thank you. I come personal. That one story, I had a daughter-in-law, and I swear that story you told about the 33-year-old was her. It sounded like she unfortunately, everything you said, the groin, the toes, she got endocarditis. She went home with a PICC line. She called me when the PICC line fell out. I was scared to death she was using drugs through her PICC line. She ended up on Suboxone. She abused her Suboxone. So I have doubts about how Suboxone works. And she ended up huffing and dying from huffing at 35. Until I was exposed to that, I had no idea what these people do and how they do it. So thank you for just being compassionate.
Thank you for sharing that.
Lori, I just want to say thank you for sharing your story. There's not any one of us who doesn't know someone, have a family member, a friend close to us. This is affecting all of us, and that's why this is so important today.
Yes, thank you. It's a great lecture.
Any other questions for Dr. Novack?
Dr. Novack, at one time, our Canadian friends were probably leading on harm reduction. At least it seemed like a few decades ago, they were kind of at the forefront of having centers for people to come in and inject, and then trying to make sure that they didn't overdose. How is it that we can't extrapolate their successes? I mean, they actually increased the overall life expectancy of all Canadians once they did this. I mean, holy smokes. I mean, that's pretty powerful, right? It may not be as good today as what it used to be because of fentanyl and stuff like that, but there is positive proof that this stuff works. It just seems like we've got to change our political will somehow in this country.
Yeah, I agree. And I mean, I encourage any of you to Google SSPs or, go to PubMed and look at any of the literature around harm reduction. It really is extensive. I mean, the science is really strong that you can significantly reduce the risk of overdose, reduce the risk of infection, reduce the risk of HIV or Hep C. I think that and I don't stay very politically active, but I think that this is an area where we really can advocate for our patients and really and like North Carolina did, we said we're not encouraging drug use, but everyone wins when we improve this. I do think and as Lori's story demonstrated, more and more, regular folks, good church attending folks have a loved one that has been affected by addiction. And so I think, I hope that the tide is turning as people have, nieces and nephews and daughters and sons that are affected by this, that it will stop being such an issue of morality or stigma, and that we really can point to some of these things as like effective, tried and true ways of improving care. I mean, if we had a study showing a cancer treatment or a diabetes treatment was this effective, like we'd have passed laws a long time ago. And so I do think that, in fact, by making it clear that this is not a political issue, it's a patient care issue, it's a population health issue, that we can help do our part to push the narrative.
All right. It is 8:59. Dr. Novack, I just want to say I am so grateful that you are on today and shared all of this information. You are such a passionate advocate in Arkansas. We're lucky to have you educating us. We also wanted to remind everyone, Jenny has posted a link in SharePoint to an evaluation. We are providing CMEs and CEUs for today's presentation. Those are in process. And so if you fill out your evaluation, send it in, we'll get those CEUs to you. Right. I want to be respectful of everyone's time. Thank you all. Have a happy Thursday, and we'll see you in March. And just for a teaser, in March, we will be having a work group that has been working on social determinants of health, led by Justin Valines, and that will be our presentation. We'll be talking about social determinants of health in March. Thanks, everyone.